It is with great pleasure that I have the honor of introducing our first speaker this morning. As our planning committee looked at all of the issues related to substance use during the perinatal period, one that really kept coming back to us was how this was impacting mothers and children, both short-term and long-term. We wanted to know more about both, about how these things impacted them in both the long run and the short run. In response, we were able to recruit one of our favorite kinds of doctors, the MD/MPH. They are the ones that can really look at a problem and not only the medical issues, but also the wider community issues as well. This is when we hit the jackpot with Dr. DuPlessis. She has an extraordinary bio, which I hope you'll go back and look at in Whova. And I can tell you from my discussions with her leading up to the summit, she is seasoned, insightful, and brilliant. So welcome, Dr. DuPlessis.
Jeanette, wow, thank you. That was a wonderful introduction. And I am really, really glad to be with you today, especially after what seems like a really powerful first day. I hope that I can contribute in a small way to how you do indeed start seeing this population of pregnant and parenting persons affected with substance use disorder differently. This is important work that you all are doing, and I'm amazed at the attendance and your ongoing commitment. So let's move forward. On the next slide, you'll see a wonderful graphic. And this is a graphic from a state opioid response initiative on perinatal substance use in California. It's not about the state opioid response grant as much as it's about the graphic, which I think does a really great job of illustrating that there's an important aspect of a continuum of care, and it even starts to preview the treatment and recovery ecosystem for this population. Ideally, on the very left, starting with identification.
Yeah, so we're interested more in the Oceanside, Carlsbad area.
And then also moving forward to treatment for persons who might have opioid use disorder with MAT or other kinds of treatment for different kinds of substance uses, and engagement and integration with what's going on in the hospital, so that as that pregnant person approaches the hospital, they are aware of and supportive of those pregnant persons and their offspring, and then warm handoffs back to treatment. So I'll just pause and say, we all know that this continuum is not always what happens. And in fact, many of our pregnant persons are presenting to the medical community for the first time at the time of delivery. And so the hospital has to have a big lift in here. But this might be an ideal depiction of what we would see. And so moving on, what we're going to cover today is just a sort of a quick overview on the agenda. We've done our welcome. I'll do a little bit of a recap on the next slide, please. I'll do a little bit of a recap of key concepts that you've talked about and a little epidemiology. We'll talk about MAT in particular for opioid use disorder. We'll talk about long and short-term outcomes of perinatal substance use disorder. I'm going to make some comments about breastfeeding because it comes up so very often. And then we'll talk about some other considerations, including legislative mandates, before we get to Q&A. And hopefully we'll have plenty of time for Q&A. I'll take a moment here just to acknowledge that in our community now, not all persons who are having children describe themselves as women or mothers. And so it is the case, certainly in a lot of research and in much of the literature, that the focus is still predominantly on women and maternal, and you may hear me say that from time to time, but I do want to acknowledge that all birthing people deserve to be able to receive respect and attain their full potential. So the next slide, I think it's always helpful to have a case, a real life case to anchor our discussion. And so Kayla is the case we talk about often. It's here for you to read. I'll point out some key aspects. She's 23. She had an unintended pregnancy that was discovered when she went for a primary care visit. She herself is the product of a single mom who had substance use disorder. She came up in poverty, was surrounded by violence, was removed from her mother's custody, raped as a teenager, had one elective pregnancy terminated earlier, and intermittently has been depressed and anxious. She also uses opioids because of a motor vehicle accident, and has used alprazolam for her, or has been given alprazolam for her anxiety disorder. She wants to keep this pregnancy. She's been forthcoming about the fact that she uses her substances sometimes more than is indicated, and she wants help. She wants to get through this pregnancy with the best possible outcomes for herself and her offspring. So on the next slide, you heard yesterday, clicking once, about Dr. Thompson's description of adverse childhood experiences, and clicking again, how those are deliberately connected and play a very critical role in toxic stress and the clear association with negative outcomes, including, click again, risky behaviors like alcohol and substance use, and unintended consequences like unintended pregnancy and fetal death. So this is a recipe for challenges in working with our population. You may also be aware on the next slide that Arizona actually has the highest ranking of children with more than 2 adverse childhood experiences in the nation. So we know we have some work to do. So let's get you started with some work by going through a poll. The first poll I'm going to put in front of you, actually it's the only poll, I'll ask you for some other questions too, is which of the following statements is false? It's a single choice. Which of the following statements is false? Go ahead and put the poll up. And the poll is also on the next slide. The first selection is that doses of methadone and buprenorphine should be increased during the course of pregnancy. Treatment with buprenorphine is not a contraindication to pregnancy. There is a significant risk of relapse for pregnant persons who were detoxed during pregnancy. And we're seeing in the chat that the polls disappeared, so we got to get the poll up again. I'll keep going on with the responses. Infants born to women who are on agonist treatment for substance use disorder, for opioid use disorder, for less than 6 weeks will not have neonatal abstinence syndrome. The use of validated verbal screening tests is generally as sensitive as toxicologic tests on biologicals in detecting perinatal substance use. And the last choice is a significant percentage of opioid-exposed infants with neonatal abstinence can be treated without pharmacotherapy. I saw the poll disappear again. Oh, there it is. Are folks able to respond to the poll? Because if not, we can use the chat. Okay, poll is up. I'm not seeing responses yet, but I'm hoping that's happening in the background. So which of the following statements is false? How are we doing on our poll participation? Jeanette, Dave.
It looks like we've got about 50, it changes fast, around 100 people so far.
Good, good, good. All right. So let's take about 10 more seconds. I know the responses are kind of long. You got to read them all. Okay. Feels like we should probably close out. What do we think? All right. So there's a real mix. Some folks think it's false that the medication-assisted treatments should be increased during pregnancy. There's 25% there, a little bit more think it's false that infants who are born to women on agonist treatment less than 6 weeks will not have NAS. All right, good. So we've got a good mix. I'm not going to tell you the answer now. We'll get the answer by the time we are through with our day together. And we'll see these questions again, so we can do that as something of a summary. And just because we want to make sure our technology is working well, we'll put another request in front of you, which is I would love to hear from you. I know there's a lot of folks on the call today, but I would love to hear from you. And don't put it in the chat yet. Don't put it in the chat yet. What information do you need to better prepare yourself to care for this population with substance use disorder or opioid use disorder and their kids? Go ahead and type, but don't press enter until I tell you to press enter. Take a few seconds, type your response about what information would help you better prepare to care for this population. Very good. This is our way to make sure that you're engaged now. Go ahead and press enter now. So we're seeing engagement strategies, community resources, absolutely. Screening questions, okay. Intervention strategies, resources comes up a lot. How to get clinics and OBs to start education, amen to that. More residential facilities. Rapport, information about resources. All right, medication impact. We'll talk a little about that today. Motivational interviewing. Yep, lots and lots. Impacts. All right, we're going to talk about the impacts of substance use on the babies and moms. Community resources. Best practice protocols. Okay. Support for breastfeeding. Wonderful. And I'm seeing resources, just a lot coming through here. And absolutely. And I know you talked a little bit about that yesterday. I hope you will have the opportunity to do a little bit more about that today. And that one of the products of this conference will be to really sort of get you focused on what resources are out there. So indeed, let's talk about so sometimes, we blow off the concept of stigma. In my mind, stigma is the big elephant in the room. It's not just something we have to tolerate, something that is out there. Rather, I believe if this isn't the most significant adverse impediment to recovery, then stigma is pretty darn close to the most significant impediment to recovery. And a powerful statement of stigma in my mind was revealed by Maya Angelou when she said on the next slide, I've learned that people will forget what you said. People will forget what you did, but people will never forget how you made them feel. That is a really clear statement of the powerful impact of stigma. And when we talk about categories of stigma, There are three. And so on this slide, I want to talk about the categories and then talk a little bit about how stigma leads to other adverse effects. You've heard, I'm sure, about self-stigma. That's the whole concept of the guilt and the shame and the worthlessness that comes from inside of us because of our upbringing, because of how we've been made to feel by often social stigma, which are those everyday societal differences that we feel and we see, and how we treat people based solely on our beliefs or our impressions. And then finally, there's structural stigma. That's sort of at the institutional level, our laws, our policies and procedures that stigmatize and discriminate against individuals with substance use disorder. There's a wonderful psychologist in California, Shelley Harrell, who describes the connection between stigma and racism and other isms. And she talks about the concept that in general, when we meet new people, we categorize them, we sort of group them. That makes sense because we've got to make sense in our own minds of folks. We pay attention to their accent, how they look, the color of their hair, et cetera, et cetera. And when we combine that categorization process with generalization, that leads to stereotypes, where we're beginning to label people. When we combine those stereotypes with our personal judgments about what those characteristics mean, that then is prejudice. It's the attitude that we now have. When we combine that attitude of prejudice with actions, how we treat people, kicking them out of a treatment program because they've had a positive screen, that becomes discrimination. Again, it's the way we start behaving. And when we are in hierarchical power positions and we have those discriminatory behaviors, or we're behaving in those discriminatory ways, that's what leads to all of the isms that we see in our society today: racism, sexism, etc. Really, really powerful. And so what can you do about stigma? You know, there's a ton that we could talk about here, and we don't have enough time to talk about how to address stigma. But in the next slide, I will suggest that a few ways that I hope are pretty common to you. The first is this concept of just increasing our own awareness of stigma in ourselves and in our programs. We got to own it. We just have to own it. We have to model not using stigmatizing communication. We may want to bring some implicit association, implicit bias tests into our organizations. We may want to find ways of respectfully calling out colleagues or others, or using videos as examples where we can point out stigmatizing language and modeling less stigmatizing language. We also want to expose ourselves to more folks with lived experience. You did that yesterday by listening to the parents. When we listen and have increased exposure, we understand then the impacts of stigma and what motivates these persons, and how it is that that they need to get past the stigma in order to get on a good recovery, get and stay on a good recovery path. Training is always appropriate. There's a whole Words Matter campaign around adopting alternative terminology, so we don't talk about dirty tests or addicted babies. We talk about a screen with results, or we talk about exposed infants, etc. And you have many resources in Arizona. One of them is the Safe and Healthy Infants and Family Thrive projects that really focuses not only on providing resources and supports, but also training and looking differently, again, to get past the stigma that our populations are often experiencing. And so moving forward, and now we gotta get rolling because I want to make sure that we have enough time to get through everything. Little bit of epidemiology nationally, as we look at the National Survey on Drug Use and Health and some of the data coming out of SAMHSA, we know that annually more than 400,000 infants are exposed to some kind of substance during their pregnancy. We have seen a 5-fold increase over the past 2 decades, but we're really not doing a really great job at making sure that treatment and support is happening when we see that 27% at least of pregnant persons with substance use disorder reported that they wanted to cut down, but they didn't know how, or they didn't need to get in treatment. And then only 8% of women with substance use disorder are actually receiving that treatment. We also know that in Arizona, substance use disorder, on the next slide, contributes to more than 38% of pregnancy-associated deaths. That's higher than the average contribution of substance use disorders to perinatal mortality in the US. And that the prevalence of pregnancy-associated deaths due to drugs increased 190% in Arizona from 2010 to 2019. I will comment, and I've seen this in state after state after state, that most overdose events for women who have pregnant and parenting persons who have substance use disorder issues occur in the 6 to 12 months postpartum. So that's the time when we don't want to lose this population. We want to make sure that we have them engaged. Those are obviously preventable deaths. We can impact that by routine screening, utilizing one of these validated screening tools that exists for the population. This slide will be there as a resource for you. I'm not going to go through all the screening tools, but I'll make a couple of comments. You know, we've organized this for you so that there are validated screening tools for the general population, for pregnant population, and for youth. So any of those tools in the middle section are appropriate for screening pregnant and parenting persons. Some of them, and we've indicated in parens there, some of them have a licensing fee. I think in California, you've gotten some relief by paying some of those licenses. And the ones that are in purple italics are screening for comorbid conditions and suicidality, which you learned yesterday and you know from your own experiences is often a comorbid condition. Behavioral health conditions are comorbid conditions with substance use disorder. So moving along, this next slide, I'm going to pause at for a moment because this is really important and I want to drive home some points. There's a lot of busy information on this slide. So first, let me orient you to the red, yellow, green table on the right-hand side of the slide. So the row headings are the outcomes, pregnancy-related outcomes. And I beg your pardon, the column headings are the pregnancy-related outcomes, and the row headings are various kinds of interventions for substance use disorder. So making a couple of really quick points, you can see very clearly in that first row, detox withdrawal, red boxes underneath overdose deaths for pregnant women, retention and treatment, pregnancy outcome. That's because every single professional organization that you can imagine, American Academy of Pediatrics, American College of OBGYN, American Society of Addiction Medicine, American Breastfeeding Medicine, I could go on and on, CDC, have come out with statements or guidelines indicating that detoxification or withdrawal, particularly from opioids during pregnancy, is contraindicated, primarily because the relapse rate is so incredibly high that it results, the relapse rate is on the order of 65 to 75%. and it often leads to overdose deaths. These are women or pregnant persons who they may want to stop themselves, but don't recognize that enough chemical changes have occurred in their brain and with their ability to produce that vital neurotransmitter dopamine, that their ability to motivate and to continue on a recovery path is really, really limited. The cravings become overwhelming and they seek drug in order to manage withdrawals. Methadone and buprenorphine are now the gold standard of care for treatment of opioid use disorder during pregnancy. We did for a long time think methadone was preferable to buprenorphine. The reality is that was mostly because we have much more experience. Methadone's been around since the 1940s and for treatment of opioid use disorder since the 1970s, and buprenorphine was only licensed by the FDA in 2010. So we know now we have enough experience with both of those medications that we know that they are very safe and very effective for treating opioid use disorder in particular. One of the responses on the poll had to do with what do you do with the doses? We also now understand that in the second and third trimester of pregnancy, we usually need to increase the doses of both methadone and buprenorphine in order to maintain the pregnant persons at a level where they're not experiencing cravings and they're not experiencing withdrawal symptoms. That has to do with a lot of physiologic changes and what's called volume of distribution that we could talk about. And we often then will split doses, particularly with methadone, so that the side effects, the sleepiness, et cetera, are not overwhelming as they would be in a large single dose. So looking then for the next slide, let's begin to talk about some of the potential long-term, pardon me, long-term and short-term effects of perinatal opioid use disorder. This is such a provocative issue, and one which, frankly, all of us have been hearing about for decades. We could talk about this for days. So instead, I'm going to make some framing comments and share with you some historical references and a little bit of information from the best studies that we have out there right now. First and foremost, I would encourage you always and everywhere, when you're reading a story or you see something in the media or you see a new article about the effects of substance exposure during pregnancy, be critical in your review and your appraisal of that. The vast majority of the literature that's out there are retrospective studies, some of them only case studies with small numbers of subjects or individuals, and you can't really draw evidence-based conclusions from those. You all know, these are the sort of the main 4 developmental domains here. So when we look at sort of good reviews of perinatal substance use and the long-term effects, and we look at sort of psychomotor development, the best studies that are out there, these are studies that are prospective or they have case controls and they go out a longer period of time. The best studies that are out there really indicate that there's no clear difference in psychomotor development in infants who are exposed long-term, in infants who are exposed to methadone versus infants who have not been exposed to methadone. When it comes to cognitive function and achievement, and that's an area that raises a lot of concern, and where many studies have been done. The best either meta-analyses or long-term studies are actually coming out of Europe. And we do now see some trends, but no significant differences when it comes to memory and cognition. So think IQ. There are, though, a couple of long-term studies in Europe and in Norway and in other European countries that have followed exposed children out to 8th grade. The European study followed them out to 8 years. And what we are seeing is that there are some demonstrated differences, significant differences in IQ and academic performance going out. Now, those studies aren't looking at interventions, where children have received interventions. They're just looking at prospective follow-up of these studies of these individuals over a period of time. No good data about language development. And there are some studies of across the US looking at 12 states, looking at some of the multi-state data that's coming out of Truven. That those studies have some limited controls, but they do at least control for socioeconomic status and environment. And we are seeing some increased risk of anxiety, autism, ADHD, and emotional disturbance in infants who have been substance exposed. And again, these are raw data without any kind of intervention involved in those instances. On the next slide, we could talk a whole long about fetal alcohol syndrome disorder. For those of you who are a little long in the tooth, like me, you'll recall that historically, we talked about fetal alcohol syndrome. Now we talk about this as a spectrum. We call it fetal alcohol spectrum disorder. And on this slide, I've sort of laid out for you the different categories of the spectrum that are now discussed in the literature. That's happened, frankly, because we just know a whole lot more about the breadth of impacts that alcohol can have on fetuses and on infants. And so that also means that our diagnoses and our criteria have been expanded. So you can see here that the old fetal alcohol syndrome that had clear, distinct facial and other physical dysmorphologies is now part of FASD. And encompasses sort of a broad complex of symptoms and presentations. In the absence of those physical features, though, there are two other conditions. We speak about alcohol-related neurodevelopmental disorder and alcohol-related birth defects. And then similarly, with or without the diagnosis of FAS, but with anything more than minimal prenatal alcohol exposure plus impairments, we have a condition called neurobehavioral disorder associated and prenatal alcohol exposure. I think my point here is not to make you experts on any of this terminology, but rather to make you more cognizant of and willing to refer for services and supports children who may have had even a small amount of alcohol exposure, whether they have what were historically stereotypic findings or not, because there are things that we can do to support that population. This next slide, I won't spend any time on, except to say the following. It's a great graphic. It's a great educational tool. And it gives me the opportunity to just remind us that, we focus on so many other drugs, but in reality, alcohol exposure is still our biggest risk. And in keeping with some of my earlier comments, I just want to make you aware that this infographic coming from the CDC is one of several. Actually, I kind of spliced two together in this infographic, but there are others that you may want to make use of and become aware of. So this is another topic that we could discuss for a long time, but today I will point out simply the following. There are no clear effects on human fetal development or brain growth. We have seen some effects in animal studies, but there aren't any human studies that demonstrate abnormal anatomic effects on the brain. There are clearly studies that have demonstrated the increased risk of preterm births, of low birth weight. And interestingly enough, those increased risks don't seem to affect long-term growth overall, with the exception of alcohol exposure. And then we'll spend a little bit more time talking about neonatal withdrawal syndrome or neonatal abstinence syndrome. I will point out here that the range of experience of neonatal abstinence syndrome in exposed infants is broad in all of the studies you will see. Part of that has to do with the fact that the exposures may vary, but part of it also, and this is probably much more likely, has to do with the fact that the condition was not suspected and then not diagnosed in the hospital. But again, underscore, this is just a dependence. This is not an addiction. Neonatal abstinence syndrome is not evidence of an addicted child. This is an older slide that I use, and I'm going to put a newer slide up in just a second. But it gives me the opportunity to say that this is a post-birth withdrawal syndrome that affects sort of three major systems in the body: the central nervous system, something we call the autonomic nervous system, which is also related to the central nervous system, but that sort of controls the thermostats in our body, our heart rate, our temperature, our respiratory rate, et cetera. And then the gastrointestinal system, where we see a lot of GI dysfunction in these infants. And there are many, many interventions. We have learned so much. Oh my gosh, I think about what I did 35 years ago, addressing the needs of infants who had neonatal abstinence syndrome, and what we know now. And, you know, it's night and day. We know so much more. And our real goals here are optimizing growth and development and attachment, and making sure that we've given these infants the opportunity to grow and have healthy lives and healthy development. I mentioned that I talk about a new definition. It's not so much new on this next slide as it is refined. You know, we have historically fallen back on using the Finnegan scale or the Finnegan index to identify or diagnose neonatal abstinence syndrome. There's a consensus group that have gotten together recently and published a refinement of the definition that really focuses on underscoring that substance withdrawal is a continuum and that expression is variable, that in utero exposure with or without psychotropic substances is one of the criteria, and that the clinical signs that are most characteristic and most common are the ones that are listed here. So the crying, the fragmented sleeping, the tremors, the muscle tone, the GI dysfunction. That starts to sound very similar to what you'll see on the next slide. And I'm sure all of you have been exposed to, have heard about Eat, Sleep, Console. Matt Grossman has spearheaded this approach and approaches like it, looking at interventions for infants with neonatal abstinence syndrome, which hopefully can avoid the use of pharmacotherapy to treat these infants, or if it's required, using it in as needed ways rather than on any kind of infusion or long-term protocol. So we hear Eat, Sleep, Console, and half of us don't even know what that is. So the eat part is, that means the infant can take at least an ounce or have a full breastfeeding session. The sleep means that infant can sleep at least an hour in between feeds. And the console is that infant, when the infant gets agitated, can stop crying on its own with a little bit of consolation help from someone outside, maybe a hand on the chest, maybe rocking, within 10 minutes of when that consolation begins. The rest of what's on this slide is the driver diagram that describes the eat, sleep, control interventions. And the next couple of slides, I'll make a few points about what you can do in your programs, what you might want to be aware of, and how you might want to educate your pregnant and parenting persons about what to expect. As we think about these changing paradigms, sure. So non-standardized kinds of interventions involve a lot of support and coaching for the parents. They don't know that pacifiers are okay, that pacifiers actually will help. It gives us an opportunity to promote breastfeeding, swaddling, and helping parents learn how to swaddle their infants really nicely and tightly in the, the old papoose style blanket is really, really helpful. Many hospitals have now developed volunteer cuddler programs where they just have individuals rocking and holding infants who have NAS or neonatal withdrawal syndrome. You want to make sure that you're protecting the skin. Some of these infants will rub their little elbows and their feet so that their elbows and their heels can get rubbed raw. So you want to, make sure that there's some protection on those pointy aspects of their skin, and environmental accommodations that make the room around them quieter, much more soothing and comforting. And when you talk about procedures and policies, hospitals and even programs now are, on the next slide, establishing policies that are supportive of these non-pharmacologic and the new understanding we have about treating exposures and withdrawal in infants. And some of those things are listed here. But perhaps what says it most effectively is on this next slide, where we need to be about the business of giving empowering messages to our parents. And this is one from Matt Grossman, where he underscores that in their hospitals, they always explain that the first line, most important treatment is the infant, is the family members. The family members are vital to comforting the infant. Parents should be the focal point of creating that attachment and making sure that these interventions are carried out effectively. So let's switch gears. I told you I was going to talk about breastfeeding because it just comes up so much. We get a lot of questions about whether parenting persons who are on MAT, who are on buprenorphine or on methadone, can breastfeed. I've been in counties, boy, and I had to really contain myself, and I don't usually get bent out of shape, but I remember working with a county where one of the individuals, and we were having a conference like this, and one of the individuals in the audience, pre-COVID, so we were in person, stood up and said, but our judges include no breastfeeding in the court order. And I just stood up and said, that's wrong. It's contrary to the science. And quite frankly, I don't tell judges how to practice on the bench. They sure as heck shouldn't be making medical decisions about what should be shared decision-making between that pregnant and parenting person and their providers. There is no contraindication to breastfeeding for someone who's on MAT. But let's go forward with all of this. I let myself get on my little soapbox here. I think we all know the benefits of breastfeeding. They're tremendous. I'm not going to go through all of them. I will just sort of point out to us all that, we're still lagging behind in the US in general. I don't mean with pregnant and parenting persons who have SUD problems. We're at about 53% in the country of breastfeeding post birth. I will point out a couple of things on the right side of this slide that might not be intuitive. One are the benefits to moms, reducing the risk of breast and ovarian cancer, obviously improving maternal and infant bonding. You may not know that there is a very strong correlation between breastfeeding and reduced risk of child abuse. And then, of course, infants who are breastfed, who are opioid exposed, do experience fewer symptoms, have less pharmacologic intervention. There are a variety of reasons for that. It's not really that they're getting medication through the breast milk. It more has to do with the bonding and the connections that are established during breastfeeding. This next slide is a pretty busy slide, so I'm gonna cut to the chase and give you the high points. There are a few very clear medical contraindications to breastfeeding. You know, those are the obvious ones. For the infants, sometimes there are mechanical problems that may make breastfeeding difficult at the outset. And then, of course, some inborn errors of metabolism that we might find on newborn screening tests may be contraindications. For the mom, certain communicable diseases that are passed through the breast milk or through the breast environment are contraindications. So, for example, breastfeeding mothers in the United States who have HIV are viewed as having a contraindication to breastfeeding. Similarly with hepatitis B and C and with herpes viruses, including varicella. That's typically because the viruses are in the blood and or when the lesions are in the breast region or the areolar region around the nipple, that easily is passed to the infants. So in those instances, if mom is uncomfortable because her breasts are full, we have to what's called pump and dump that milk. We don't want to give that breast milk to the infant. On the other hand, there are communicable diseases like tuberculosis or COVID. A parenting person who has tuberculosis but perhaps has not been completely treated, or someone who has COVID shouldn't be close enough to that infant to have that respiratory contact, but that individual most certainly can pump and have that breast milk delivered to the infant by another person until such time as they are out of contagion for those kinds of respiratory spread communicable diseases. Other situations, certainly a pregnant person or a parenting person who has substance use disorder and is not in treatment, or they have heavy alcohol consumption and even cannabis use, we would recommend against breastfeeding. Clearly, issues around cannabis use are very controversial. We will know in the next 5 or 7 years as the studies come pouring in more definitively what to say about breastfeeding with cannabis use. Certainly, someone who's not in treatment is at risk for engaging in other risky behaviors that further put the infant at risk. But bottom line here is MAT is not a contraindication. And so as we talk about what to do to support pregnant persons who may want to breastfeed, the first and foremost, and this is something you can certainly do in your treatment programs and in your community support programs, is work with these moms and pregnant persons before they deliver to formulate a plan for how they want that delivery and their peripartum period to go, and include breastfeeding in that plan and provide them with accurate education and information about breastfeeding under different circumstances, including treatment with MAT, with methadone and buprenorphine. Naltrexone similarly. Methadone, buprenorphine, naltrexone, all are excreted in breast milk in very, 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 very small concentrations. So not enough to make any significant difference in the infant. And then, engage in what we call shared decision-making, where moms get information so that they can make their own decisions. I will say as an aside, the most significant factor influencing whether or not a woman with substance use disorder breastfeeds is what she hears from other pregnant and parenting persons. So if you have groups and you're having conversations about breastfeeding, make sure you bring someone into the table where you can provide accurate and complete information about breastfeeding, lest you have one of your other moms be a bit too influential, but perhaps not share information that is completely accurate. Okay, so we're going to shift gears and head to the finish line here by talking about some other considerations. Staying here for just a moment. You know, as we're working to support and empower pregnant and parenting persons and their families affected by substance use disorder, we have to remember that no matter how we feel and what we've done, the environment in which we live is really challenging. And it's on us to try to help our clients navigate that environment so that they can realize the best outcome for themselves and for their families. That includes, on the next slide, unfortunately, a pretty punitive legal system that is a function and a manifestation of that systemic stigma that we were talking about a little earlier. On this slide, I included a statute from the state of California, not because it's driving anything significant, but that it has historic significance as one of the first statutes, came out in 1991, taking an alternative approach, recognizing that the toxicology screen in and of itself isn't evidence of child abuse or neglect. Since that time, and what drives most of our decision-making and our programs are the federal pieces of legislation. The Child Abuse Prevention and Treatment Act has been around, CAPTA, has been around, oh man, for a long time, for a couple of decades, 70s, I think. Most recently amended in 2016 in ways that I'll point out in a moment. And part of that amendment was the Comprehensive Addiction and Recovery Act language. So a couple of things came out of those 2016 amendments, one of which was the requirement to notify, and it says notify Child Protective Services when there are indications of maternal substance use, including legal drugs. So a nod here to alcohol and other things, prescription drugs, when there's any kind of risk to children. The other thing that came out of the 2016 amendments was the concept of a plan of safe care that we'll talk about in just a second. But before we get there, this next slide is kind of busy, but tracks state policy approaches to perinatal substance use from 2000 on the left to 2015 on the right. You know, we know that research shows that criminalizing perinatal substance use leads to worse outcomes for the pregnant persons. It leads to worse outcomes for the infants. And it is often very discriminatory. Bottom line, really decreasing the likelihood of seeking care. What you can see here, so the gray states are states where there's no perinatal substance use policy or law. The states in green have policies or laws that are supportive only. The states in red, kind of that red-orange color, have only punitive policies. And the states in brown have policies that are both punitive and supportive, or maybe I should say they have both punitive and supportive policies. And so what you can see here is over time, there's a lot less green from 2000 to 2015. So states that had only supportive policies. and a whole lot more brown, where they now have both policies that are punitive as well as supportive, and some new red states. So I suppose if the glass was half full here, there's progress in some respects, but a real underscoring of how incredibly punitive and how very provocative this topic and this challenge is. There are, at this point, 20 national organizations that have statements or guidelines against punitive practices. I've listed a couple of them here, but we have work to do. Thank you. And despite the consensus of all of those professional and national organizations, we still see increases in prosecution, as you can see here. And we still see, quite honestly, a lot of real confusion and incredible variability in how child welfare systems at the state level and at the local level are interpreting that Child Abuse Prevention and Treatment Act amendment, those mandates. I mean, we see it up and down the state of California. We've seen it in other states that, you know, the local CPS agencies, they just don't know what to do. So they do what they think is best. And it's in our best interest, certainly in the children and families' best interest, for us to really try to be clear in our policies and in our approaches, and really, really educate our child protective services system and all the related systems that they touch about how to interpret and what really is most useful for this population. Final two slides here. What can we do? So what are the ways in which we can support our infants and our pregnant and parenting persons? Well, ideal approaches are ones that are multidisciplinary and that are reinforced. I mentioned the plan of safe care. This is essentially a care plan that is built to meet the needs of both the pregnant person and the infant and family. Ideally, that plan of safe care, which, by the way, legislatively is required to incorporate the planning for a plan of safe care document, is supposed to incorporate hospital staff, child protective services, and medical and public health staff. So ideally, that plan of safe care might be developed during the prenatal period, and then it follows that pregnant person through the delivery and beyond. Again, because so many of these persons end up presenting for the first time in the hospital, it often is developed or may need to be developed in the hospital setting. In addition to that plan of safe care, though, we want to have and build more programs and treatment opportunities that are experienced and stable and focus on the needs of pregnant persons, including those trauma-informed approaches that we spoke about yesterday. We want to make sure that our medical and neurodevelopmental monitoring for baby is early and often and adequate. That means sometimes the primary care provider may or may not be comfortable caring for and being cognizant of the needs of an exposed infant. So you might need to look for a high-risk infant follow-up or another setting where the primary care or the medical folks were more comfortable monitoring and managing those infants over the long term. And then a nod to the protective factors with which I expect many of you are familiar. Those are the ones over on the right there that are associated with successful families and reductions in child abuse and neglect. This next slide, I won't spend any time on, except to say I wanted to put it in here as a resource for you because I didn't know if Dr. Thompson would have included it. This is a great roadmap for building trauma-informed care practices in your organizations. And then we get to revisit the poll. So we can go 2 slides forward to the polling questions. And by now, you probably recognize that the statement that is false is D. So infants who are born to moms on agonist treatment, they'll probably still have neonatal abstinence syndrome, but they will have an easier time, or those infants will have an easier time managing that neonatal abstinence syndrome. The pregnancy and the mom and the infant will have better health outcomes in the long run for that person having been on MAT. And I think we've got some resources there over the next few slides, and I think we still have some good time for questions. All right, Cecilia's glad she got it right. So I haven't been able to manage the chat the whole time. Jeanette, others?
That's okay.
Here.
We're on it. We've been monitoring it and tracking the questions. So if you're ready, I'll start. The first one that came in was, what do you think about EPDS, from Rosie Simpson?
Oh, help me.
I don't know what EPDS is.
I'm not sure what she means. At first, when she first said it, I was thinking, she was saying EPSDT. Oh, the Edinburgh scale?
Edinburgh.
Oh, right. Okay, yeah, sure.
Oh,
funny, I was just having this conversation with someone. So the Edinburgh is great, is a great depression screen for pregnancy. There's controversy about whether the Edinburgh is better than the PHQ-9. I think the reality is it comes down to what you're more comfortable with. I will say about validated screening tools, you know, I made a lot about the I made a lot of distinction about the validation part of the screening tool. But remember, those screening tools are just a vehicle for us to establish a conversation, to establish rapport. So if the provider is more comfortable with the Edinburgh, hey, go for it, use it. I think decisions about Edinburgh versus PHQ-9 come down a lot to practical considerations. Can I get it in my electronic medical record? The other thing about the PHQ-9, of course, is it includes comprehensive, it is more closely aligned with the DSM-5 criteria for depression. On the other hand, the Edinburgh includes items both for depression and for anxiety. And you know that, you know, our concerns are for perinatal mood and anxiety disorder. So I've given you a lot of information, but I'm not going to come down on one side of the fence or another. I hope that's helpful.
Great. The next one is, I work in the NICU and find that the babies whose mom was on buprenorphine go through a much more difficult time after delivery versus methadone. Is this being looked at or considered when prescribing?
Well, I will say that's an interesting observation, because my own personal experience and the experience of most of the individuals that I've been, my professional colleagues, is that buprenorphine is better tolerated by the infants than is methadone, that is to say fewer NAS symptoms. But I would suspect, quite honestly, that the difference you see may be more a function of how those pregnant persons are induced and what kind of dosages they're maintained on versus the actual distinction in the drug. Well,
that makes sense, because the next comment came from Clay Jones, and he said, I have heard just the opposite.
Yeah,
that methadone is harder on babies. So, right. Okay. The next one is, does the dosage of these medications have any effect on withdrawal?
And are you asking of withdrawal of the infant or the mom?
This is from Cindy. Cindy, can you unmute and clarify?
I was thinking, like the dosage that mom is on, does it affect the withdrawal the baby goes through? If she's on more methadone, does it have a stronger withdrawal, basically?
Yeah, it's a good question. And I will say, sort of anecdotally, no, although I will acknowledge that, you know, the use of higher doses of methadone in particular in the second and third trimester of pregnancy is relatively recent, by which I mean the last 3 to 5 years. So I don't know that we have good data on that just yet, but my hunch is it doesn't make a whole lot of difference. And I'm focusing more on methadone than buprenorphine, because methadone as an agent does not have what we call a ceiling effect. That is to say, the higher the dose of methadone, the higher the side effects. And anybody who's been on methadone can tell you that. There's a difference between being on 100 milligrams of methadone and being on 140 milligrams of methadone in terms of side effects. So I don't know about the methadone. The dosage ranges for buprenorphine are narrow enough, and frankly, buprenorphine does have a ceiling effect. That is to say, you can go to higher doses of buprenorphine and you won't see more side effects. It'll just sort of cap out. So we haven't seen that affecting infants at all. The dosage range of buprenorphine affected the infants.
The next question is, are MAT programs available everywhere in the state?
That's a good question.
We might need some input from our audience, because Dr. DuPlessis isn't from Arizona, and
I know Arizona has MAT. I know they have been working hard to expand access to MAT, but I too am anxious to hear from others more knowledgeable about whether it's available everywhere in the state.
oh, here Heidi's saying Brenna Koch says she will cover that later. Okay.
All right, good.
That's good. And then there's a request to see that first infographic of your session again.
Oh, that beautiful graphic?
Yeah.
That was, I think, the second slide. So if the person who can control it, put that up.
And we're going to have the slides available.
Yeah.
Yeah. So, all right. I think that's it.
Anything else? There's that great slide. Yeah. And was there a question about this, or did you just want to see the great graph?
I think they wanted to just get access to it, and you can see it here. And then we're going to have the slides available after the conference.
I will make one other comment just about this slide, since it's back up here.
Sure,
You'll
sure.
see in there CMQCC, CPQCC, California Maternal Quality Care Collaborative, and the California Perinatal Quality Care Collaborative. Those are our, perinatal quality collaboratives. We partnered with them in this initiative in large part because we knew we had to do work with the hospitals, and it was really quite the experience. Hospitals are tough places when it comes to making changes in policy and really sort of changing the hearts and minds of and here's a stereotype that's going to come from me, labor and delivery nurses who've been doing their thing and doing it really well for many decades. Often they know how hard it is for these pregnant persons, but sometimes they need to be persuaded, and bringing persons with lived experiences and bringing the science, quite honestly, is one way to do that.
Well, Dr. DuPlessis, I just want to say that when you were doing your presentation, if it were possible to hear applause, you would have heard a whole lot of it when you were talking about breastfeeding, because we had so many comments of people saying, yes, way to clarify and way to support breastfeeding. So
all right, good for you. And I saw that practicing medicine from the bench in there somewhere.
yeah, I think they've heard of that one before. So
I'll bet.
Yeah.
Well, but that's work we got to do with the justice and the judicial system as well. And it's slow but steady. We're getting there.
Definitely. Well, thank you so much. You gave us exactly what we were hoping to get out of this presentation. So I thank you so very much.
Well, thank you for inviting me. Keep doing good work.